2 minutes past the hour, so I think we should go ahead and get started. I'm Zach Fasolis. I'm a neonatologist at Washington University, and I wanted to thank all of you, all 121 of you, for joining us today. We're really excited to hear these talks, and I'm excited to present this on behalf of the Neonatal NIRS Consortium. I have a slide up on the screen right now that you've all been able to look at while we were getting ready to get started. Just describing what we have done in the past. We've had some meetups at previous PAS meetings, and we would like to continue that in the future once PAS starts happening again. And then we also have started quarterly webinars. We've had 2 so far this year, and we plan on having another one later this summer. We'll have a poll about that a little bit later in this session, and we're interested to hear what you guys would like to hear about at future sessions. So we're really excited today to have 4 trainees who are going to be presenting work that was accepted originally at PAS for presentation, but unfortunately they didn't get to share. So they're gonna let us know all about it today. We're gonna be hearing from the 4 speakers that are in the blue box on the left side of the screen. And then our first presenter is Vivek Shukla, who's University of Alabama. And he'll be presenting on the effect of indomethacin prophylaxis on cerebral and abdominal tissue oxygenation by NIRS and preterm infants. Just a reminder for everybody in the audience, let's keep all of our microphones on mute throughout the whole presentation. We'll have time for questions at the end of each presentation, but let's do that just by the chat box. So each presenter has moderators, me, Jonathan Mintzner, who's at Mountainside Medical Center, and Valerie Chalk, who's at Stanford University, will be helping to moderate this session. We have a couple of our own questions, but we would love to incorporate the questions that you guys have too. So please enter those in the chat box as we go along, and we'll get to the questions at the end of each presentation. So I'm going to go ahead and stop sharing my screen now so that Dr. Shukla can take over.
Thank you, Dr. Vasalis. Is my screen visible?
Yes, looks great.
Okay, thank you. So thank you for this opportunity. I'm going to present the study on effect of indomethacin prophylaxis on cerebral and abdominal tissue oxygenation by near-infrared spectroscopy in preterm units. So I have no conflicts of interest to disclose. No external funding was sought for this project. Early indomethacin prophylaxis for preterm units decreases the incidence of severe IVH, hemodynamically significant PDA, and need for PDA ligation. However, these benefits have not been shown in long-term outcomes, so the practice of indomethacin prophylaxis varies between institutes. Near-infrared spectroscopy is a great way of monitoring. It is non-invasive. It provides continuous trends. It's very easily interpretable. And many uses have been described, but the most commonly used are cerebral and abdominal NIRS. Near-infrared spectroscopy is much more useful than pulse ox because it provides an insight into the interplay between oxygen delivery, metabolism, and perfusion. Concerns have been raised for indomethacin-associated reduction in cerebral and abdominal tissue perfusion, which can increase the risk for adverse neuro and gastrointestinal outcomes in preterm units. Effect of indomethacin on cerebral and abdominal tissue perfusion by NIRS and its correlation with outcomes has not been evaluated. So our objective was to determine the effect of single dose of indomethacin given within the first 6 hours after birth on cerebral and abdominal NIRS and the association of NIRS values with death and or short-term neuro and gastrointestinal morbidities in preterm units. So this was a cohort study. The study period was from May 2018 to April 2020. We enrolled 200 consecutive preterm neonates who had gestational ages between 25 to 29 weeks. We included neonates who had more than 40% of FiO2 requirement or ventilatory support requirement on admission. Early cerebral NIRS from birth to 3 days, and abdominal NIRS from birth to 7 days values. Short-term neuromorbidities including intraventricular hemorrhage, periventricular leukomalacia, retinopathy of prematurity more than stage 2, and abnormal neuro exam at discharge. Short-term gastrointestinal morbidities including necrotizing enterocolitis of Bell's stage 2 or more, or spontaneous intestinal perforation, and mortality were recorded. Neonates were grouped by exposure to early indomethacin prophylaxis. In the study NICU, early indomethacin prophylaxis is given to majority of neonates less than 30 weeks gestation, except for those who have antenatal concerns for abnormal uterine artery Dopplers, who are small for gestational age. There is some degree of attending preference, and there have been a few kids we missed administration of indomethacin because we could not give in the first 6 hours. We use descriptive analysis to compare the groups. We use univariate and multivariate association analysis to see the effect of indomethacin on outcomes and cerebral and abdominal NIRS. So this table shows the baseline characteristics of the groups. I want to preface this table by saying that this is not a randomized controlled trial, so the results should be interpreted accordingly. We had a higher birth weight in indomethacin prophylaxis group as expected. We had lower death and hemodynamically significant PDA incidence in the indomethacin prophylaxis group. There was no difference between the groups in terms of death and or neuro or GI morbidities. So this figure shows the trend of cerebral NIRS values by group. On the x-axis, it describes the time since birth. On the y-axis is the cerebral NIRS with mean and standard error. The red line describes is for the indomethacin prophylaxis group, and the blue line is for the control group. And as shown in this figure, the cerebral NIRS values were significantly higher in indomethacin group for the first 12 hours. The cerebral NIRS values between the two groups was not statistically different from 12 to 72 hours. This is a similar figure for abdominal NIRS values by groups. And in this, we see the abdominal NIRS values for the first 12 hours were higher in the indomethacin group. The values from 12 hours to 3 days were not statistically different. And the abdominal NIRS values from day 4 to day 7 were significantly higher in the indomethacin group. All p-values were less than 0.01. There are significant limitations to the study, including this is a single center study. It's an observational non-blinded study. Other factors that can potentially impact tissue oxygenation, like oxygen saturation, blood pressure, CO2 levels, although they are closely monitored and managed as per evidence-based unit protocols for all neonates, were not adjusted in the analysis. So to conclude, early indomethacin prophylaxis is associated with significantly higher cerebral and abdominal tissue oxygenation in the first 12 hours after birth, and significantly higher abdominal tissue oxygenation from 4 to 7 days after birth. The mechanism of such association needs to be further investigated by a more in-depth bench and clinical study. The role of abdominal tissue oxygenation values in early identification of hemodynamically significant PDA could be further explored. I want to thank all the wonderful members of the UAB NeuroNICU team, and I'm open to questions. Thank you.
All right. Thank you so much for that great presentation. Dr. Mincer needed to step away to take care of some clinical stuff, so Dr. Chalk will be filling in for him as a moderator for this session too. For those of you that are watching along, please enter any questions you have down in the chat box, and we'll discuss. So one question to get you started off with here. What do you think the mechanism is that connects this early prophylaxis with the higher abdominal saturations, particularly as you go out in time?
Yes, sir. So what my speculation is that the indomethacin group had significantly low numbers of hemodynamically significant PDA, and that could be represented in the differences that we are seeing.
Um, a sort of a related question, where did you guys put your abdominal NIRS probes?
So we, by protocol, we put on the right side of abdomen. We prefer to place it around liver if we are able to place it top. If there are any ongoing issues or we need that area for some other things, then we can also place on the left side.
Um, what was the rationale in continuing cerebral or abdominal monitoring for so much longer than your cerebral monitoring?
Yes, sir. So cerebral, we also were continuing to monitor, but we didn't analyze because our hypothesis was that the IVH, which happens is most commonly around the delivery. And like there have been studies that show that IVH like starts to happen around delivery and then progresses. So we only wanted to focus the first 3 days for cerebralness, and for abdominal NIRS, we thought like we would have better idea if we go on till 7 days to see the association with necrotizing enterocolitis, which develops later on.
Hmm. There's a lot of questions in the chat box that sort of deal with the reliability of abdominal NIRS monitoring. So do you think this is a pretty good proxy for mesenteric saturation? How reliable do you think it is? Do you use it in clinical practice at all?
Yes, so we have a unit protocol. Our staff has been very well trained in applying NIRS and monitoring NIRS. We have not started intervening based on the NIRS yet because we were trying to get more data on what the effect of different numbers or what cutoffs should we use, because most of the studies that have been done are from as you know, term neonates or bigger pediatric studies. So we wanted to have specific uh, thresholds for preterm neonates and specific for our unit. So that's the reason why we wanted to get this study done first and then to have interventions.
Valerie, what questions do you have?
Yeah, I think this is a great presentation, Vivek. Thank you so much. One of the main questions that have come up for some of us is kind of maybe to clarify who actually gets the prophylactic indomethacin at your institution, because maybe you're selecting for a different group of babies, maybe ones that are sicker, more premature babies to begin with. So I'm just wondering how much of the NIRS values kind of reflect the babies that are actually getting the prophylactic indocin.
Yes, thank you for that question. So uh, our unit protocol is most of the babies who are less than 30 weeks gestation get indomethacin prophylaxis, except for those with uterine artery Doppler anomalies who are SGA, and there has been some attending preference with indomethacin. So about, I would say 40% of those less than 30 weeks don't get because of these reasons. And the other 60% were the ones that got.
Yeah. Okay. No, that's interesting, because we noticed in your inclusion criteria, the babies had to be on at least 40% FiO2. Do you think that may have affected the overall NIRS values to be higher than what other centers might be seeing?
Thank you for that question. Yes, that might be one of the reasons. Our inclusion was more than 40% FiO2 requirement to better utilize our NIRS monitors. But yes, that could be one of the reasons that we are seeing more values in our group.
Interesting. And I know that in the literature, we see at higher doses of indocin, we do tend to see a transient decrease in your sats over a couple hours, but it doesn't seem like you notice that as far as the relation to the timing of the dose itself.
Yeah, so the dose usually is given within the first hour. If we are able to get access and everything, it can be stretched out to 6 hours as per our unit protocol. And to be honest, we were surprised to see the difference that you see in the cerebral NIRS. We were not expecting to see the difference. And also with the abdominal NIRS, I don't have any speculation on why we are seeing this difference. I think we need to do more bench work to better understand that.
One of the questions that also was in the chat box that I had as well is if you were able to compare the cerebral to the abdominal sats to get an idea of the differential blood flow to both sites. Like some people do like a splanchnic cerebral oxygenation ratio.
Thank you for that question. So as you see, our inclusion, like we included babies from May 2018 to April 2020. We just recently completed the analysis for the presentation. We are undergoing further analysis, which will see that differential oxygenation gradient as well.
Great. Zach, did you want to get other questions from the chat box?
There was one question about the dosing of your indomethacin. So why just a single dose of indomethacin?
Thank you for that question. So the TIP trial used 3 doses, and we as a group, we were using 3 doses, but then depending on the randomized control trial from the University of South Alabama by Dr. Rambhat, his trial basically showed that 1 dose is as efficient as 3 doses. So our unit protocol changed from 3 doses to 1 dose.
And all of the babies included in your study got that particular dosing regimen?
Yeah.
Okay. I think that's most of the questions we have, and we're sort of, I think, at the time limit. Thank you so much for that presentation. That was fantastic.
Thank you.
So I think we will move on to our next speaker, and Dr. Chalk will be introducing her.
Yeah, we're really excited to have Sarah Justvig from Stony Brook Children's Hospital speaking about the correlation between neonatal abstinence syndrome scores and cerebral and peripheral muscle fractional tissue oxygen extraction, or FTOE, in term neonates at risk for NAS.
Thank you very much. Can you see my first slide?
Yes, we can.
Thank you. Okay. Hello, everyone, and thank you for the chance to speak with you today. Okay, our research team has no conflicts of interest to disclose, and our project was supported by an American Academy of Pediatrics resident research grant and IRB approved at Stony Brook University. Given the well-documented ongoing opioid epidemic, neonatal abstinence syndrome, or NAS, has become a major issue in newborn care. As you can see from the figure, between 2009 and 2012, the incidence of NAS almost doubled. Between 2000 and 2012, the incidence of NAS in the United States rose almost 5-fold. Finding better ways to manage this increasingly common condition has become a critical concern. NAS causes multi-system disturbances and affects neurologic processing. It impacts the release of multiple neurotransmitters, raising concern for both the short and long-term effects of fetal opioid exposure and postnatal opioid treatment on the newborn brain. Management of NAS is typically begun with supportive care. Medications such as morphine are added when supportive care is ineffective or high NIS scores remain. Morphine has been established as helpful, but its effects on neurodevelopmental outcomes are uncertain. We currently determine NIS scoring and severity using scoring systems such as the modified Finnegan. Finnegan scores are given by the infant's nurse every 3 hours based on central nervous system, metabolic, vasomotor, respiratory, and gastrointestinal disturbances. High scores indicate more severe withdrawal. While the Finnegan provides a trended measure of disease severity in these numeric scores, it is highly subjective. Thus, an objective, reliable, and trendable estimate of NIS severity in neonates would represent an important advance in the management of this increasingly common condition. Near-infrared spectroscopy, or NIRS, as seen here, is a non-invasive technique to evaluate and trend individual tissue oxygen saturation at the bedside. Similar to pulse oximetry, or SpO2, which reports global anticipated oxygen input to tissues via arterialized vessels, NIRS evaluates regional tissue oxygen saturation, or RSO2, arising from all hemoglobin sources within a given tissue. NIRS represents a predominantly post-capillary tissue oxygenation measure specific to the anatomic region being studied. By simultaneously measuring SpO2 and RSO2, one can derive a trendable balance between oxygen supply, or SpO2, and individual tissue oxygen consumption, RSO2. The most commonly used calculation integrating the two into a trendable measure of tissue oxygen utilization is fractional tissue oxygen extraction, or FTOE, the formula for which is shown here. Overall, given the inherent variability associated with NIS scoring utilizing subjective symptom-based parameters, we were interested in evaluating whether NIRS-based oxygenation data may provide a more objective, yet similarly trendable, assessment of NIS severity. Therefore, in this proof of concept, prospective, observational cohort study, we sought to determine whether NIRS-derived cerebral and peripheral muscle RSO2 and FTOE demonstrated physiologically plausible changes in tissue oxygenation behavior that correlated with standard NIS scoring measures. Our monitoring sites were cerebral, sensor was placed across the forehead, and peripheral muscle, sensor was placed down the right thigh. Cerebral NIRS has been well studied in neonates, while peripheral muscle has not. We hypothesized that among opiate-exposed well baby nursery neonates at risk for NIS, those with elevated NIS scores, greater than or equal to 8 by convention, would demonstrate a 10% higher cerebral and peripheral muscle FTOE, indicative of increased tissue oxygen utilization, compared to similarly at-risk neonates without elevated NIS scores. We secondarily hypothesized that non-pharmacological measures, specifically swaddling, would be associated with a 10% increase in RSO2 with a proportional decrease in organ-specific FTOE. Well baby nursery infants at risk for NIS with positive toxicology for opioids, current medical plan including NIS scoring, and mother 18 years of age or older were included. Exclusion criteria included medical conditions requiring transfer to NICU, major congenital anomalies, and mother incarcerated and therefore not able to provide consent. Subjects underwent cerebral and peripheral muscle NIRS monitoring prior to a single feed on days of life 3, 5, and 7. Each session included 20 minutes in the crib, followed by 10 minutes swaddled and held. Ideally, the infants were held by mom if she was available. Otherwise, they were held by me. To ensure elimination of excess variables, I went through the consent process with each mom and performed the entirety of the data collection for each baby, coordinating study times around scheduled feeding times, placing the sensors on each baby's forehead and thigh, remaining at the bedside throughout each monitoring interval, and swaddling each baby when it was time. Each baby also had his or her own set of NIRS sensors. The infants were categorized by day of life, elevated versus non-elevated NIS scores, single versus multi-drug exposure, whether they were exposed to buprenorphine in utero, and whether they were treated with morphine during their well-baby nursery stay. Our data set included 28,440 data points. On sample size calculations, taking into account 3 monitoring sessions per subject, a total of 30 subjects was determined to be sufficient to determine our desired differences with 80% power and a two-tailed alpha of 0.05. 30 neonates with mean gestational age 39 weeks and mean birth weight 3,127 grams were enrolled. Table 1 shows correlations between NAS scores and cerebral FTOE. As you can see, the correlations between NAS score and FTOE are in the positive direction for all but one category, meaning higher NAS scores or more withdrawal is correlated with higher oxygen utilization and vice versa, as we expected. But these correlations are not statistically significant, as none reach the 0.05 threshold. Overall, regardless of day of life and swaddling and holding status, absolute NAS score was not statistically significantly correlated with cerebral FTOE. These scatter plots express the information from the table in a more individualized way, plotting the NAS score and FTOE for each baby on each day of monitoring. Parts A, B, and C correspond to days of life 3, 5, and 7, respectively. Honing in on day of life 7, for example, you see NAS score plotted on the x-axis and FTOE plotted on the y-axis. Blue points correspond to pre-swaddling, red points to swaddling, and correlations are represented by the dotted lines. As you can see, the correlations between NAS score and FTOE are visibly in the positive direction, though not reaching statistical significance. Table 2 shows correlations between NAS scores and peripheral FTOE. Here, some correlations are in the positive direction and others are in the negative direction, depending on the day of life and pre-swaddling versus swaddling status, but no correlations reached statistical significance. Again, overall, regardless of day of life and swaddling or holding status, absolute NAS score was not statistically significantly correlated with peripheral FTOE. Table 3 shows some of the data from our division of the infants into ever elevated NAS score versus never elevated NAS score, meaning did the infant ever have a modified Finnegan score of 8 or higher while in the nursery. Part 1 of the table, shown here, focuses on the infants who had at least one high NAS score during their nursery stay. The columns show cerebral data, further divided into pre-swaddling and swaddling, followed by the p-value, and then peripheral muscle data, again, further divided into pre-swaddling and swaddling, followed by the p-value. While there are no statistically significant effects, for babies with at least one high NAS score, the directionality of the cerebral data is correct according to our hypothesis on days of life 5 and 7, the p-values of 0.13 and 0.08 respectively. Perhaps we could see a statistically significant difference with a larger sample size. The directionality of the peripheral data is counter to our hypothesis on days of life 3 and 5 for babies with at least one high NAS score. Of note, the swaddling period and holding period was the 10 minutes immediately prior to a feed, theoretically when the infant's withdrawal would be at its worst, possibly contributing to this difference. Overall, there were no statistically significant effects of swaddling on cerebral and peripheral muscle FTOE based on NAS scores. Part 2 of the table focuses on infants who never had an NAS score of 8 or higher while in the nursery. Again, there were no statistically significant effects of swaddling on cerebral and peripheral FTOE based on NAS scores. Interestingly, though, when we divided the sample by exposure to buprenorphine, there was a statistically significant improvement in FTOE on day of life 7 when babies exposed to buprenorphine were swaddled, with a p-value of 0.03. Our study was a pilot project to examine the use of NIRS in the neonatal population at risk for NAS. Overall, tissue oxygenation monitoring demonstrates potential to provide objective physiologic information on acute withdrawal among infants at risk for NAS. Further studies with larger sample sizes are required to best determine correlations with currently accepted NAS scoring strategies. Thank you all. Thank you most especially to my mentors, Dr. Mincer and Dr. Sridhar, for their creativity, insights, and inspiration, as well as to my entire research team. I welcome any questions. Thank you.
Thank you so much. This is a really interesting study, and I think highlights a potential newer opportunity for the use of NIRS monitoring in a different population. Um, Please, if everyone has any questions for Sarah, please enter it into the chat box. I'm going to start us off. Can you tell us a little bit of why you selected for the peripheral site using the thigh versus maybe another somatic site like the abdomen or kidneys that have been used before, and how the effect of movement might play into that?
Absolutely, that's a great question. So knowing that cerebral data was something that was well studied in NIRS, we wanted to have as a second site something that wasn't as well studied, but perhaps was less invasive. So if we saw that the cerebral and peripheral data were similar and that the two correlated, maybe we could only use the second one in the future if that was less invasive for the babies. It's funny that you mention about the movement, because since I was the one actually doing putting the sensors on and being there for the actual data collection and those monitoring periods, I found that the sensor that the babies liked the least was actually the peripheral muscle one. They were trying to kick that one off versus the cerebral one they were pretty content with having. So it turns out that, first of all, the gold standard and our newer ones didn't correlate. And also, I think that what was sort of less invasive to the babies, in a sense, was the cerebral one. But the peripheral muscle site, being the thigh, was for it to be non-invasive, meaning it was literally outside the baby's diaper, didn't require any extra fussing, changing, anything that would affect the baby. But interestingly, really thinking about our results, it makes sense that the cerebral and the peripheral data aren't the same. And so cerebral is so stable, right? Babies will redistribute blood flow to protect their brains in times of physiologic stress, versus a peripheral monitoring site would be more likely to show any subtle illness-related changes in oxygen utilization before you would see those changes in the brain. So it really shouldn't be so surprising that those numbers are different, but that's why we picked the sites that we did.
Great, thank you. One other question that I had was the timing of the monitoring. So were these babies swaddled and held and monitored per cues, or was it a set schedule for their feeding? Because that might have some implications for withdrawal.
Absolutely. Yes, they were on a set feeding schedule. Typically, they were just fed every 3 hours in the newborn nursery. So we picked the half hour before that feed. So if the feed was at noon, then the monitoring period was 11:30 a.m. to noon. The first 20 minutes of that were in the crib, and the last 10 minutes of that was the swaddled and held portion. And we realized that, as I said, that could have affected our data in the sense that they were maybe withdrawing a little more when they were hungrier, and it was that much closer to their feed during the swaddling and holding time. And we purposely picked the swaddling and holding time to be the end instead of the beginning, or else if we had seen that there was a change and the numbers were better when they were swaddled and held, we would have had to say, well, what if that was just because they were withdrawing less because they weren't as hungry?
Makes sense. Yeah. And then we have a bunch of questions. I'm just going to get to one more here about have you looked at the data based on components of the Finnegan score? So for example, like CNS abnormalities versus the GI symptoms, et cetera. And maybe the numbers aren't big enough to really say much about it, but I'm just curious if you're able to break it down at all.
That's a very interesting point, and we were using the absolute scores, but we do have that information available, and that's a great idea for a further sub-analysis to do and think about.
Great. Zach, did you want to try to moderate some of the questions from the chat box?
Yes, yeah, there's some great questions in there. And then I also had one of my own before we talk about those. So most of your comparisons were swaddled and unswaddled, but I saw that you also collected information on whether babies were being treated with morphine or not. Do you have enough numbers, or is there enough variance to be able to look at the impact of morphine on these measures?
Yes, about a quarter of the babies were treated with morphine. I think it was 23%. And there were not statistically significant differences. Where we did see a difference was buprenorphine, and we chose to subdivide by buprenorphine because we know it has a longer half-life and it has some properties that are different than other opiates. And that was the one that babies who had been exposed to buprenorphine tended to really respond to the intervention. So I think part of what we were really looking at was, is there an ideal candidate for this type of an intervention? And it seems like babies who have been exposed to buprenorphine might be those ideal candidates, especially later on in their stay, later on in their withdrawal, where their withdrawal might be peaking, as opposed to another baby with different exposures who might be past their peak of withdrawal at that point.
Sure. One that kind of combines some of the questions in the chat and something I was thinking, how long are your recordings? How much time are these FTUE measures based on?
So there's a recording taken every 5 seconds. So 12 recordings a minute. So over 30 minutes, we're getting 360 data points.
Okay. There's a question in the chat about the babies you excluded, the ones that needed to be admitted to the NICU. This might be more of a question about the particular practices in your NICU, about which babies stay in well baby versus which ones go to the NICU. How might that have influenced your outcomes?
Sure, that's a good point. So we all know that a common complication of neonatal abstinence syndrome is dehydration. If they're jittery, hyperthermic, having diarrhea, having skin excoriations, etc., and get dehydrated, they often need intravenous fluids. And at my institution, that is an indication for transfer to the NICU. So I think that's probably the most common reason an NAS baby would be in the NICU as opposed to with us and therefore excluded from the study. And yes, it is possible that that's affecting our results, but we really couldn't include babies who were in the NICU because often they had other anomalies that then would be, or other just issues going on that would be co-founders and therefore difficult to stratify what was due to our intervention and what was not due to our intervention. In general, the feedback that we got actually starting off the study was that we were going to have difficulty consenting families because it's such a vulnerable population. And I think actually the most surprising thing about our work was our consent rate was almost 80%. It was a lot higher than any of us really could have predicted. And we found that these families were so generous in wanting to help other families in the future not want to go through what their child was going through if there was anything more that we could learn about it. And getting to bond with them and hearing their stories was the most rewarding part of getting to do this work.
That's really impressive. Congratulations. I've done studies in this population before, and I've not been able to come anywhere close to that consent rate. So that's a big sign of how successful you guys were. Then I guess one other quick question, and I think this is a great one. Do you think the NIRS monitoring itself influenced the NAS scores of these babies? That having the sensor on, people being around them, do you think that changed the score?
Oh, that's a very interesting point. Actually, something that I haven't talked about is the timing of those scores. So the scores were actually taken a half an hour after the feed. So they were monitored for the 30 minutes prior to the feed, then they were fed, and then a half an hour later is when the nurse would get all the baby's vital signs and score them. So they weren't actually undergoing a monitoring interval when they were getting scored.
Okay, sounds great. Thank you so much for presenting. I'm gonna take the screen back over here for a second, and we'll do just a really brief intermission here. We are so happy that all of you guys have joined us today. Let me get the right slides up here first. Two things that I wanted to go through. Number one, if you are not already on our mailing list for our NIRS Consortium events, please feel free to email the same email address that you sent to RSVP, so neonatal.nirs@gmail.com, and let us know that you would like to join our mailing list. We'll add you on, and then we'll send you all the announcements for our next quarterly webinar that's coming up, as well as events that are taking place at conferences in the future. So we have one quick thing we'd like to ask of you guys. We have a small poll to actually try to figure out what we should cover for the next session. So we have 4 different ideas that we've come up with. NIRS with a variety of different conditions that babies face in the NICU. And we would love for you guys to go ahead and vote for which one you'd like to hear about the most. And we'll try to pick speakers and presentations that match that. So we'll give a few minutes here for people to register their thoughts. And then shortly we will head on to the next presenter. I don't know if you guys can see the results. I'll share them at the end. It's a close competition between at least 2 of the topics here. right, we'll do one more minute for people to register their requests, or sooner if everybody votes by then. All right, I'm going to go ahead and end the poll here. So I will share this. I think, can you guys see this? I'm not sure what this looks like on your end. This is my first time doing a poll, but it looks like NIRS and HIE / cooling, it was the winner. Not by much though, it was a close one, 35 to 30%. All right, so for the next topic, Dr. Mincer, I'm pretty sure, Jonathan, I think you're introducing the next one.
Yes, I'm back.
And then I will share Christina's slides, so I'll get those up on the screen in just a second. All right.
Second, okay. So our next presentation will be by Christina Erickson out of Maria Ferrari Children's Hospital, my own alma mater there. And the title of her talk is The Correlation Between Splanchnic Fractional Tissue Oxygen Extraction, or FTOE, and Hematocrit in Extremely Low Gestational Age Infants.
Hi, everyone. Thank you so much for having me. So Dr. Vassoulis, if you can just advance my slide, please. So I have nothing to disclose today. Next slide, please. So anemia is seen almost universally in our ELBW population, and that's for various reasons, including frequent blood draws, decreased production of erythropoietin, shortened lifespan of the preterm RBCs, as well as an inability of the premature bone marrow to keep up with these ongoing losses and subsequent deficits. So while we know that anemia occurs frequently, and in this specific population, we typically let the hematocrit fall down into the low 20s, how low is too low becomes the question, and what impact may the anemia be having throughout the infant's body? So when is it time for us to intervene? And this is going to be a question I'll be referring back to throughout my talk. Next slide, please. So in the setting of anemia, the body will attempt to compensate in order to maintain the appropriate amount of oxygen delivery. And it will do that through mechanisms such as increasing cardiac output, increasing endogenous erythropoietin release, hypoxic vasodilation in order to improve blood flow in order to maintain oxygen delivery, as well as increasing oxygen extraction. Next slide, please. So if we think about oxygen consumption versus delivery, where delivery is going to be flow times content, of course being dependent on hemoglobin concentration, there's a plateau along which the infant can lie with a falling hematocrit. So if you look at the graph above, along that line that says aerobic metabolism, as an infant has a falling hematocrit, they will continue to move to the left along that line. And the baby may try to compensate by increasing blood flow, increasing oxygen extraction, and you won't see any adverse effects because you're still meeting the demand for oxygen consumption. However, at a certain point, the body will be unable to continue to compensate. So when you've maximally dilated your blood vessels to increase flow, you've maximized your ability to further increase oxygen extraction, which usually occurs around 80%. At that point, you'll exceed your body's ability to deliver oxygen, creating an oxygen delivery consumption imbalance and then subsequent injury. So if we could have a sense of where along that plateau each infant is by determining how much oxygen they're extracting, it would be useful in helping us determine how close they are to that critical O2 point and prevent them from falling off the cliff, so to speak. Next slide, please. So anemia can have a significant impact on the gut specifically, and that's because of the physiology of the microvasculature of the gut. So at baseline, each individual intestinal villi is actually supplied by only a single feeding arteriole, and that has a PO2 as low as 10 at the tip. So therefore, any disruption in oxygen delivery could lead to injury in that site. And in fact, studies have shown that anemia can lead to a chronic state of inflammation in the gut. It can impair splanchnic perfusion, as well as impairing maturation of the vascular autoregulation in the premature intestine. There was a study by Patel et al. That also found that severe anemia increased in ELBW infants' risk of NEC by 6-fold. Next slide, please. Another article by Singh et al. Also looked at anemia and its relationship to NEC, and what they showed was that the probability of developing NEC increased significantly as the hematocrit dropped. So if you look at the above graph, with a hematocrit around 45, let's say, the predicted probability of NEC was about 0.1, versus if you drop down to hematocrit of 25, that predicted probability increases to 0.5. So again, you see the significant 5-fold increase in the risk of NEC with a falling hematocrit. Additionally, in this study, they also found that if you transfuse these anemic infants, there was a potential to further increase the risk for NEC. So it's possible that some of these infants, when they're so severely anemic, they are too close to that critical O2 point that I mentioned before, and any type of a secondary insult, such as a transfusion in this instance, could push the infant over the edge and lead to subsequent injury. So again, I come back to that question of how low is too low, and when do we need to intervene, and when is it safe for us to intervene? Next slide, please. There have been several randomized control trials over the years, as well as the TOP trial, which is still ongoing, that have looked at using stricter versus more liberal transfusion criteria in the NICU. And I'm not going to go into these trials specifically, but just overall, essentially, they have found conflicting and pretty much inconclusive results. And this may be due to the fact that hematocrit alone is not really enough information to determine which infants are truly in need of intervention and which ones are truly at risk compared to those who are not. Next slide, please. So that's where NIRS comes in. So near-infrared spectroscopy measures the ratio of oxygenated to total hemoglobin in a specific block of tissue that's comprised primarily of venous blood. And therefore, we can use it as a surrogate marker for mixed local venous oxygen saturation. Next slide, please. This was a study that looked at infants that were undergoing transfusion while cerebral, renal, and splanchnic NIRS were all being monitored. So on the top, you can see the pulse oximeter data, which is circled, and it's pretty stable. It did not have any significant change during the transfusion. Below that is the cerebral, renal, and splanchnic NIRS signal. And what you can see there is that during the transfusion, after the transfusion, the NIRS signal at all 3 of those sites increased. And that makes sense because you're increasing your oxygen content by replacing hemoglobin with the transfusion. Therefore, the body does not need to extract as much oxygen, so you have an increase in your NIRS signal or venous O2 content. Next slide, please. So we can use that NIRS information with the pulse oximeter data in order to calculate exactly how much oxygen is being extracted at various sites. And that can be helpful, especially in the anemic preterm infant, in determining where they are along that plateau, as I had mentioned previously. Next slide, please. So we wanted to evaluate the relationship between local fractional tissue oxygen extraction and hematocrit in LVAN infants. Next slide, please. So we had 11 infants in this study with an average gestational age of about 25 weeks, an average hematocrit of 24 at the time of the study. And I just want to draw your attention to the bottom here where the cerebral flank and splanchnic oxygen extraction values are. And so at baseline, with the in these anemic infants, the cerebral and flank oxygen extraction is already at 40%. In the splanchnic site, you're actually above 60%, which is exceedingly high for a baby to just be sitting at when they're that anemic. Next slide, please. So when we tried to see if there was any correlation between hematocrit and the amount of oxygen that those babies were extracting, we did not see any significant correlation in the cerebral or the flank site. And so each of these dots is just one of those 11 babies, and you can see that there's a wide distribution there amongst those infants. Next slide, please. Similarly, in the splanchnic site, we also did not find a significant correlation between oxygen extraction and the hematocrit. But what was interesting about the splanchnic site is that this, you can see there are multiple babies here who have a very high extraction, as I mentioned previously. So 5 of these babies had oxygen extraction above 60 and even close to 80%, whereas in the flank or the cerebral site, either none of the babies or only one of the infants had any oxygen extraction that was greater than 60%. So again, it's suggesting that there's something that's unique about the gut, and maybe why those 2 previous articles by Patel and Singh et al. Showed that there was an increased risk of NEC in these severely anemic babies because their extraction can be so extraordinarily high. Next slide, please. Oh, sorry, next slide again. So then we looked to see if there was any correlation between oxygen extraction and postmenstrual age in each of those 3 sites. So again, for cerebral and flank, we did not find a significant correlation, although the data does seem to have slightly more of a trend here than it did with the hematocrit. Next slide, please. But when we looked at the splanchnic site, there actually was a significant correlation with postmenstrual age. And again, if you just look at those individual dots, for those infants who are corrected to 30 weeks or less, their rate of oxygen extraction in the splanchnic site was all exceedingly high, with most of them being around 80%. When you look beyond the 30-week mark, most of those babies had an average fractional extraction around 40%. So this we found to be very interesting and sort of an unexpected finding, but it could be explained by the fact that around that 30 to 31 week mark, there is a period of rapid intestinal growth and subsequent rapid intestinal vascular growth as well. So it's possible that those less mature babies, the ones who are less than or 30 weeks or less, have to rely more heavily on oxygen extraction because they cannot compensate by increasing blood flow. And then maybe subsequently those babies who are more mature can compensate by increasing blood flow and do not need to extract as much oxygen. Next slide, please. So we concluded that hematocrit thresholds alone are not an accurate representation of which infants are going to be at the most risk for having inadequate oxygen delivery. We also concluded that during extreme anemia, those infants with a postmenstrual age less than 31 weeks had a higher increase in fractional extraction of oxygen, possibly, again, like I said, due to that inability to compensate by increasing blood flow. So we feel that NIRS may be used as an alternative or additive measure to assess adequate oxygen delivery and potentially even transfusion thresholds, since there was no correlation between the amount of oxygen being extracted and hematocrit. And it may be particularly useful in these extremely preterm infants who are below 30 weeks. Next slide. That's all I have. Thank you so much. And I'll take any questions.
Great. Thank you very much for an excellent presentation. And I see that there are some questions entering into the chat, and would invite anyone who'd like to ask any additional questions to please insert them into the chat box as well. A question of my own was, could you shed some light on how exactly the NIRS data were being collected? Many of these babies would be 4 to 5 weeks old, so was NIRS data collection occurring during a certain point in their feeding cycle? And also, how long of an interval were you collecting NIRS data over?
Sure. So the interval that we collected was for an hour, and actually the majority of these babies, so I believe 9 out of the 11 babies were all on continuous feeds because they were all smaller. So at our institution, if a baby is usually around 1,000 grams is when we switch them over to Q2 feeds, but some of these babies were actually a little bit bigger, but still on continuous feeds. So most of them were just continuously being fed, and you know, we're still getting their feeds during the time when we recorded the NIRS signal. And it was just that one hour interval. So that was the point that we averaged, that 1 hour interval.
Okay, very well. Another question, just from my own set of questions, is among the 11 babies studied in this trial, any potential variables or confounders that would affect the relationship between FTOE and postmenstrual age? There could be quite a number of other pathologies going on in this population.
Sure, that's a great question. We did look at the
information about that.
Oh, sorry, my Google Alexa thinks that you're asking her a question. So we didn't find any other significant variables. We are collecting that data, but nothing that we could see that corresponded to the findings that we found other than the postmenstrual age.
Okay, very well. Looking at our chat box here, where was the NIRS device applied for the mesenteric signal?
Sure, so we did it inferior to the umbilicus, and usually we did it to the left side as well. Some of the babies, when they're smaller, they sort of just end up being in the middle, not really much to the left or the right, but just essentially inferior to the umbilicus.
Very well. I assume there was these babies were now large enough to have enough real estate for placement of the probe beneath the umbilicus.
Yes, for the most part, yeah.
Okay. Another question from the chat box. You know, splanchnic NIRS signals are known to be very variable. There's been numerous papers that have described that. How representative overall do you feel a NIRS value, a mean NIRS value with the standard deviation, et cetera, is, especially for the splanchnic circulation? In additionally, especially if that's being taken over a full hour's interval while a baby's being fed?
Sure, that's a great question. So, I mean, overall, I think that really NIRS should be used more for trend monitoring than for an absolute value. But just in my experience, having put these NIRS probes on a lot of these significantly anemic babies for a variety of my studies that I've done, there still seems to really be no correlation between, for instance, if I see a baby that has a hematocrit of 22 and I put the splanchnic probe on, you know, I've seen values that have been 15, which is the lowest, you know, limit of detection that our machine can do, and then I've seen values of 45 in babies that seemingly are identical. So that says to me that there is a lot of variability from baby to baby. So I don't know if there's an absolute, like, would we be able to use that NIRS probe and say, okay, at this exact value is when you need to transfuse? I'm not sure, but I think when you just look at each individual baby over time, you can still, you know, use that information reliably more for like trend monitoring.
I see what you're saying. So this strengthens the case for longitudinal monitoring rather than just 1 hour in particular.
Yes, exactly.
Okay. See if there's any other questions. Valerie, would you like to add any, if there are any?
Sure. Christina, this was really interesting. One question I had, I know this wasn't an outcomes-based study, but do you have any information about your cohort on who might have developed NEC or mortality data on this cohort?
Sure. So out of the 11 babies, there was one who ended up developing NEC. So that baby was transfused and developed NEC within 24 hours of the transfusion. And that baby in particular, the hematocrit was 23 at the time that we transfused. The baby was an X25 weeker who was corrected to a little over 28 weeks. So right in that population that we saw that had that very high oxygen extraction in the gut. And I believe that baby's oxygen extraction in the gut at the time of our study was 84. So it's pretty much at his maximum capacity.
Interesting. And did you look at the degree of anemia and how that correlated with the baby's postmenstrual age?
We did not directly, but just from sort of looking at the numbers grossly, it doesn't really seem that there is a correlation. But I mean, I could do that analysis officially, but it doesn't really seem like there is. I mean, 7 out of the 11 babies had a hematocrit between 21 to 23. So most of them were sort of just in that range.
Got it. Okay. Great. Well, I know there are other questions in the chat box, but I don't know, maybe in the interest of time, we can maybe ask you to respond to them individually so we can finish up our presentations.
Sure. Thank you so much.
All right. Well, we are ready for our final presentation of the day today. Our final one is Pulak Agrawal from Loma Linda University in California, who will be presenting the effect of delayed cord clamping on cerebral blood flow and oxygenation in near-term lambs.
Hello, everyone. Thank you for this opportunity. Can everyone see my screen well?
Yes, looks great.
Okay, thank you. So I'm going to talk about effect of delayed cord clamping on cerebral blood flow and oxygenation in near-term lambs. Little bit of background. So we know that all the committees like American Academy of Pediatrics, ILCOR, ACOG have recommended routine delayed cord clamping in all the births, and the time period that they recommend is anywhere between 1 to 3 minutes. So what are the benefits of delayed cord clamping? There have been numerous papers on this. A Cochrane review done in 2013 showed a significant increase in infant birth weight, hemoglobin concentrations, and iron reserves for up to 6 months after birth. Judith Mercer et al. Published in Pediatrics in 2006 and showed that delayed cord clamping was associated with decreased need for blood transfusions and lower incidence of neck sepsis, and for the purpose of this study, most importantly, intraventricular hemorrhage of all grades. H. Popet in 2019 published a paper that showed that it may show improved cerebral oxygenation in preterm infants following birth if they're subjected to delayed cord clamping at birth. So let's look at how cerebral blood flow is affected by delayed cord clamping. So sequence of oxygenation and clamping of the cord is vital and is known to significantly affect cerebral blood flow. So when birth happens, there is pulmonary ventilation, which causes oxygenation, and this oxygen constricts the blood vessels in the brain. This potentially protects from fluctuations that happen from the systemic blood pressure and can be theorized as a mechanism to prevent intraventricular hemorrhage. So Sasmira Bhatt et al. Published this in Journal of Physiology, and it clearly shows the difference between clamping and ventilation before clamping of the cord. So you can see that these two graphs, the time 0 shows clamping of the cord. The dark circles are unventilated lamps where they have just clamped the cord and ventilation is not yet established. The open circles are ventilated lamps, which means they are ventilating them first. So you can see in terms of arterial pressure in the carotid artery, you can see huge fluctuations in the non-ventilated group and more stable blood pressure in the ventilated group. Moving on to the bottom graph, the carotid arterial flow, they used it as a surrogate for cerebral blood flow. We do know, however, carotid artery does supply also the skull and the face, so it may not be an exact marker for cerebral blood flow. So unventilated lamps showed huge fluctuations again with cord clamping, and actually you can see the blood flow going down compared to ventilated lamps where the blood flow is pretty stable in the carotid artery. So our objective is, the study was on 2 parts. The first one is to evaluate the effect of delayed cord clamping on brain tissue oxygen or TPO2 and regional cerebral saturation or STO2 using NIRS during birth and hypoxia in term lambs. We experimented on near-term lambs, so the gestational age was 138 to 142 days. The lambs were instrumented in utero. Flow probes were placed in the brachial artery to measure arterial blood pressure. Laser Doppler flow probe was placed in the cerebral cortex after making a burr hole in the skull, and this helped to measure cerebral blood flow and also tissue PO2. This is the picture of the laser Doppler flow probe. NIRS was applied on the forehead for regional saturation. We intubated the lambs through their trachea and placed them back into the uterus for baseline data recording. We then delivered the lambs with their cords intact. We sedated them and ventilated them at birth, aiming to have a PCO2 of 40 to 50 millimeters mercury, and then assigned them to either immediate or delayed cord clamping groups. I want to focus on how our tissue PO2 probe works. So this is an example of how the cerebral blood flow is actually being measured. So there is an incident fiber, there's a fiber which sends incident light, and there's another one which receives the scattered light. The area where it's being measured is about 1 cubic millimeter, and the red cells are either static or moving. So depending on whether they're stopped or whether they're flowing, there's different wavelengths of lights being scattered, which are picked up by this fiber. And that's how cerebral blood flow is calculated in this region of the brain. And this is another diagram showing the composite probe. You can see this is only 400 micrometers. It has 4 parts to it. We saw the emission and the receiving fiber, and this is the oxygen probe. It releases a fluorescent dye, and that dye is quenched in proportion to how much oxygen is actually in the regional tissue, in the local tissue where it's inserted. And that's how it measures tissue PO2 in millimeters of mercury. And this is a thermocouple that adjusts for temperature. I do want to mention that the cerebral blood flow measured by the laser Doppler flow probe is a relative value and does not give an absolute blood flow value. So it's a comparison from baseline. This is an example of our protocol. So 0 marks the time of birth, where we delivered, ventilated, and performed clamping immediately at birth in the immediate group. Before birth, they were monitored for 30 minutes as the baseline, and then after birth for 20 minutes. We did the exact same protocol in the delayed group, except after delivery, the clamping was delayed by 5 minutes in these groups. We included 16 term lambs. 7 of them were in the immediate group and 9 in the delayed group. So let's look at what happens to the blood pressure. In these graphs, y-axis is the blood pressure, x-axis is the time period in minutes, and blue dots represent immediate cord clamping group, and the red dots represent the delayed cord clamping group. I've also marked time of birth at 0 and time of clamping in case of DCC group at 5 minutes. So as you can see, let's focus on the blue dots for a second. The blood pressure rises after birth, which is not surprising. But in the delayed group, you can see that after birth, it actually does not tend to rise, but only rises after we clamp the cord itself. Moving on to cerebral blood flow. This, as I talked before, is a percentage of baseline. So this is the baseline period. And you can see there is not much statistical significantly different values between the two groups. And again, this is the clamping and ventilation, and this is ventilation in the delayed group and clamping in the delayed group. Moving on to the brain tissue PO2, we have shown this again as a percentage of baseline. In the blue group or the immediate group, you can see it has a tendency to decrease during birth before increasing again. Compare this with the delayed group, where the tendency is not to decrease as much and increase thereafter. This difference does not seem to be statistically significant, but it is definitely, you can see the difference between the two groups. Cerebral vascular resistance was also variable, and there was no difference between the two groups statistically. So our results reinforce that blood pressure increases with clamping of cord and not with ventilation. Brain hypoxia can be avoided after birth using delayed cord clamping, as it allows for continued oxygenation of the brain before the cord is clamped. So these may be the basis for evidence for reduced IVH in delayed cord clamping in infants. Moving on to our second objective, to evaluate the effect of hypoxia on cerebral blood flow following birth in term lambs. So the cerebral response to hypoxia in the fetus is well known and published. It is due to 2 reasons: increased systemic blood pressure and vasodilation of cerebral vasculature. Responses of brain vasculature to hypoxic insult in the newborn have not been studied. So let's look at what happens to the fetal brain in response to hypoxia. So the fetal brain has the ability to increase blood flow in response to a hypoxic insult. It is the brain sparing mechanism and serves to maintain oxygen delivery to the fetal brain at the expense of other organs. This is a previously published paper from our lab, and I want to show the effect of hypoxia on blood pressure. The blue bar is the hypoxia, and you can see the blood pressure rises above baseline during hypoxic interval. Similarly, the blood flow or the percentage of blood flow from baseline also rises during hypoxia in the fetus. So for this part of the study, we use the same animals as we talked about earlier, but subjected them to hypoxia 30 minutes after birth. So delivered, ventilated, and clamped, observed for 30 minutes, and then subjected to hypoxia by mixing nitrogen in their inspired air, and then allowed them to recover for 30 minutes after that. And this was in both immediate and delayed groups. Further now, I will be showing together the term LAMs and not be differentiating between immediate and delayed, because when we analyzed them, it did not seem to show a major difference, but I do want to emphasize the effect of hypoxia. So let's see what hypoxia does. So tissue PO2, which was measured by the brain probe, shown in the above graph, shows that we subjected them to hypoxia and made them pretty hypoxic, below 10 mmHg. So for reference, a fetus has tissue PO2 in the brain of about 10 to 12. A newborn has about 40. We made the newborn lamb hypoxic even by a fetus's standards, so less than 10 mmHg. And this shows the regional saturations of percent oxyhemoglobin measured by the NIRS on the forehead of the lambs. And you can see that if you compare the two graphs, the trend seems to correlate pretty well, and the NIRS falls nicely during hypoxia, and this, these 4 data points were significant over time. So when we want to correlate how good is NIRS compared to the actual brain tissue PO2 measured by our probe inserted in the brain, you see a linear relationship, and the coefficient of correlation is 0.74, and this was statistically significant. So with lower PO2 values, there were lower NIRS values or regional saturation values. So the arterial blood pressure, you can see with hypoxia on the top graph, at 0 again is time of birth, the blood pressure rises, and during hypoxia, it had a tendency to fall and not increase. I want to remind of the fetus response. The one that I just showed was the newborn response. And now let's see on the right, the fetus responded with an increase in blood pressure with hypoxia. So this is completely opposite of what has been previously published in the newborn. So the heart rate similarly shows an increase with hypoxia and then decreased compared to the fetus where there is bradycardia with hypoxia. Now looking at the cerebral blood flow as a percentage of baseline, again, this is the newborn that we did experiments on, and the hypoxia shows not a tendency to rise, but a tendency to maybe even fall compared to baseline during hypoxia. Compare this with the fetus. Again, with hypoxia, the fetus had clearly an increase in the cerebral blood flow with hypoxia. Talking about cerebral vascular resistance, with birth, it increased, and with hypoxia, cerebral vascular resistance tended to decrease. So we can conclude that the newborn lamb responds to hypoxia without an increase in blood pressure and cerebral blood flow, as opposed to the response of the fetus. And regional cerebral saturations measured using NIRS correlate well with cerebral tissue oxygen tension during hypoxia. So our findings in the newborn lamb are opposite to that of previously studied findings in the fetus when subjected to hypoxia. Newborn lamb responds with a decrease in blood pressure and cerebral blood flow. So why do we think that is? So the blood pressure and blood flow are dependent on a balance between vasoconstrictors and vasodilators. When normally birth happens, there is a surge in vasoconstrictors. The sympathetic system fires and catecholamines are on the rise. Various other factors are on the rise that cause systemic vasoconstriction. Now we subject this infant or a lamb to hypoxia. When hypoxia happens, there's again two responses. One is the vasoconstriction by the sympathetic system. Another is the local vasodilation in the brain and some other organs. So we think that maybe at birth, these vasoconstrictor systems are being overwhelmed. And when we subject the lamb to hypoxia, they are not able to further increase the vasoconstriction because of birth, they are already at a heightened response. So the balance gets tipped over to the vasodilators, thus not showing an increase in blood pressure and blood flow in the lamb. Of course, we need more studies and measurement of these factors to say anything about association or evidence for this reason. So to summarize, the study shows that regional saturation can be used as a good marker for cerebral oxygenation. Regional saturation measured via NIRS correlates well to actual brain tissue PO2 measured using a probe implanted in the cerebral cortex in lambs with R of 0.74. And NIRS can be reliably used to trend changes in oxygenation during physiologic changes like hypoxia. And that's all I have. I would like to thank Dr. Blood, who's my mentor, and everybody who has supported me in our research. Thank you.
All right, thank you. Great presentation. Really enjoyed hearing that. So we have a bunch of questions in the chat box, and then we have some that we've thought of in advance. One that I was wondering about, this is a relatively long delay period that you used for these lambs, longer than what a lot of us are using clinically. One is, was there a particular reason you chose 5 minutes? And then a related question, did you measure the hematocrits in the two groups to see how much of an impact, perhaps guess how much blood was actually transfused?
Great questions, thank you. So the first question, yes, so 5 minutes we decided based on, yes, the literature, different studies have mentioned anywhere between 1 to 3 minutes, but to see the maximal effect and show that it's actually feasible and be able to see the maximal effect of ventilation, letting the pulmonary vascular resistance fall down, and see the effects of delayed cord clamping, we decided to go with 5 minutes. And even to support that, if we found that this made a huge difference, then we could advocate for a longer cord clamping time to improve placental transfusion. To address the second part of the question, could you repeat that, please?
Sure. Yeah, I shouldn't have asked two at one time. Did you measure hematocrits in the two groups to see
yes.
the difference?
Thank you. Yeah, so we did measure hematocrits. We did serial blood gases, and we do have that data. We did not show it in this presentation. And we also are measuring oxygen content based on that. I unfortunately don't have the graphs to show you.
Okay. One question in the chat box, is this an example, I think they're talking about your hypoxia model of a difference between primary and secondary apnea.
That's interesting. I think it is a little different because we did continue ventilation. The secondary apnea would cause increase in, even primary apnea would cause increase in the PCO2, which also causes changes in cerebral blood flow. We tried to do isocapnic hypoxia. So we continued the ventilation, we just reduced the oxygenation. So I think those are two different models.
One thing that I was wondering, looking at some of your graphs earlier on, the big question in delayed cord clamping is, where's this blood going that we're transfusing? Which compartment is it going into? And some of the studies that have compared ventilated versus unventilated neonates suggest that just delayed cord clamping by itself without ventilation doesn't really transfuse much blood, because it's actually the pulmonary space that this blood goes into. Obviously, you've taken that out of the equation by ventilating both groups, but I was wondering what your thoughts were on the effect of all this pulmonary blood and the blood pressure, the systemic blood pressure.
Yeah, that's a good point. I totally agree with what you said about it going into the pulmonary space, and we definitely ventilated both groups. So we had enough time for them to get ventilated before delaying the cord in terms of delayed cord clamping. I'm not sure whether that contributes to the blood pressure. I think the blood pressure rise, as we saw in the graph, was mainly after the clamping itself, the mechanical effect of the clamp, and also the surge in the catecholamines, but not by itself delaying and increasing the blood volume. So I think ventilation establishment and decreasing pulmonary vascular resistance was helping in this placental transfusion, but I think that the blood pressure rises is only happening after the clamp, which tells that although the increased blood is going in the lungs, but that is not essentially contributing to the higher blood pressure.
Okay, great. I had one more question, and then I'm going to turn it over to Jonathan. You presented all delayed cord clamping lambs. Have you looked at all at cord milking in babies to see if that has any similar effects or different effects?
That's a great point. We actually have not used cord milking in these models, but that's a good comparison.
All right, Jonathan, turn it over to you.
I really only have one question left over, but any proposed follow-up studies to further assess the effects of delayed cord clamping, or especially longer or shorter durations of delayed cord clamping for any particular organ effects outside of the brain? Because it seems that brain tissue PeO2 is variable, but with consistent cerebral blood flow between your two groups. So I wonder what you speculate would happen with other organ systems.
Yeah, that's a great point. I think different organ systems, it would be unchallenging because we don't have great validated measures for measuring the perfusion or regional saturations, except for, of course, mesenteric. I think we focused on the brain because we have the ability to measure accurately and reliably the tissue PO2 in the brain by this probe, and we could maybe another way to go about it is to measure it maybe in the renal system or the mesenteric system using NIRS. But we were planning to focus on explaining why the effect of hypoxia happens and actually measuring the factors that could be causing it.
Understood. Well, thank you very much for an excellent presentation and a very provocative study. I look forward to seeing more from your group.
Thank you so much.
All right, Zach, that's all I have.
Okay. All right. Well, I wanted to thank all the presenters for sharing your work today, everybody in the audience who joined us, and all the fantastic questions you asked. Please let us know if you haven't already, if you'd like to join us for the next one of these sessions, which will be on June 4th. We have 3 speakers lined up for that coming up next week. And if you have any other questions or would like to sign up for our email list, just go ahead and send us an email. Otherwise, have a great weekend.